Corneal ulcers can be defined as a breach in the continuity of the corneal epithelium, and it can be resulting due to multiple etiological factors over here. When we discuss and when we look into these predisposing etiological factors, they can be of the infective origin, and mainly the infections can be due to the viral, bacterial, or they can be even of the fungal origin over here. Particularly in this lecture, we'll be summarizing the viral causes, that is basically the viral infections, which can result in the corneal ulcerations. We can classify these corneal ulcerations depending upon the shape of the ulcers over here. So there are multiple examples for these corneal ulcerations. Either they can be the punctate causes, we have the decimatforms, that is basically a ring-shaped corneal ulcers, or there can be the multiple other shapes of these corneal ulcers that we usually clinically observe. So it's again very interesting to have a look at these different shapes that these viral causative factors can cause at the corneal epithelium. As well as we have to keep in mind that these viruses, when we talk about them, we'll be talking about the major viruses that are causing or that are basically resulting in the corneal ulcerations over here. The most notorious of them are the Herpes Simplex virus, and then we have the Herpes zoster virus. So these are the most notorious viruses, and they have their typical clinical pictures when we are looking at the patients of corneal ulcerations, and whenever we are suspecting that this patient might be suffering from this corneal ulceration where the etiology is basically viral in origin over here. So particularly when we are talking about the Herpes Simplex virus. Now, Herpes Simplex virus is majorly of two types. We have a type 1 Herpes Simplex virus, and then on the other hand, we have a type 2 Herpes Simplex virus. So both of them are quite notorious for developing these kind of ulcerations at the cornea. We have to remember that this is basically a DNA-based virus, and we have to remember that it's epitheliotropic. So this is the sensitivity of this virus. It's more tropic, means basically loving. So it's basically more loving towards the epithelium and is going to involve the epithelium mainly rather than the neurons. So some of the viruses are neurotropic in origin and some of them are epitheliotropic. So this is their nature. This is the nature of the viruses. And when we are studying the viruses and their particular behavior and their particular clinical outcomes, we have to keep in mind the origin, the final structure of the virus, as well as what are the clinical features that it is going to present in a particular case of herpes simplex virus. So when we say that this herpes simplex virus is affecting the cornea, it is causing the keratitis, that is the infection of the cornea, it's not just being complicated by the ulcers. Sometimes it's just the infection that it is causing. So this can be one of the features that this herpes simplex virus is presenting with. And we have to remember that the only host for this herpes simplex virus is man. So it doesn't have any other host. So it has to attack the human beings more importantly or more majorly. This is a particular picture, as you can see over here, of the herpes simplex keratitis. How is it going to look? It's basically fluorescein stained and is going to highlight the typical ulcers that it is going to form, due to this herpes simplex keratitis in the patients. Then the etiological factors, we already know that we have two types for this herpes simplex virus. One is the type 1 and then we have the type 2 viruses. So there are these particular differences. Usually the type 1 virus is attacking the body of the human beings. That is, the major area involved is above the waist, and the type 2 virus is usually involving the area of the body that is usually the genitals, or which is lower down than the waist. So this is a typical thing. It's not a rule, of course, but you can remember it by this by keeping this thing in your mind, that these are the major areas that are going to be affected whenever a host is going to be attacked by the type 1 or type 2 viruses. Now moving on to the herpes simplex keratitis and how is it infected? What are the ways that it can be transferred? When we are discussing that, basically the type 1 viruses has its own modes of transmissions and the type 2 viruses have their own modes of infections. So over here, when we are discussing the type 1 infections and we are taking into account how it can be transmitted from an infected individual to a normal healthy individual, the most common route of transmission is by coming in contact with a patient who is suffering from herpes labialis. Now, as the name is indicating, basically herpes labialis is whenever this herpes simplex virus is affecting the lips of the patient. So that is basically going to be known as herpes labialis, and it is often transferred or acquired by kissing. So this is the mode of transfer when we are discussing the herpes simplex type 1 infections over here. Regarding the type 2 infections, usually it causes the ocular lesions and through infected genitals of the mother. Whenever we say it is transferred on to the baby through the affected genitals of the mother, it's during birth infection. The infections which are basically acquired during the period, which is basically the parturition period, the period where the labor is taking place. So this is how the infections can be transferred from the genitals of the mother to the newborn. It can be transmitted to the eyes of the neonates, and this is how usually it would be a newborn infant having a mucopurulent discharge, inflammation, swelling, and that would basically indicate that he or she has acquired this ophthalmia neonatorum, which is the basic cause over here is the herpes simplex type 2 infections, which are carried on through the genitals of the mother. Now, regarding the ocular lesions, when we are considering whenever there would be an infection which is caused by the herpes simplex virus, it can be a primary herpes simplex keratitis or an ulceration. Either it can be a recurrent one, and then we can have the systemic involvements as well. So just regarding or just considering the ocular lesions over here, we are considering whenever we have the primary herpes, that would basically present to you in the outpatient departments with the skin lesions, then the conjunctiva and the acute follicular conjunctivitis, and then the cornea can be involved as well. So what are the typical skin lesions that this patient would be suffering from? There would be a scabbing phenomena that is usually seen in the viral skin lesions. This is very particular. You usually observe that the skin lesions which are caused due to a virus, that would have a scab which is formed, that would be basically preceded by a mucopurulent discharge which was present at that particular area of the skin, and then it was replaced by the development of a scab. So this is usually the typical particular presentation of a skin lesion in cases of the herpes simplex virus. It can involve any of the areas, even of the facial features, even it can involve the lips, the skin. So all of these are basically prone to the development of these skin lesions. Then, of course, it's not just the cornea that is involved when we're talking about the ocular lesions. It can be even the conjunctiva that is involved. Sometimes this is a collective condition. The terminology of keratoconjunctivitis is used rather than just keratitis or just isolately we're using conjunctivitis. It's sometimes quite an intermingled picture in which the conjunctiva as well as the cornea are affected by the viral infective states. So whenever the conjunctiva is involved, it can be an acute follicular conjunctivitis. It can be even a mucopurulent kind of a conjunctivitis. So there can be a discharge that the patient is suffering from, or whenever you look at it, there would be the features of follicles and papilla that are seen on the bulbar part of the conjunctiva. And mainly you can really appreciate whenever you evert the lid, there would be this formation of follicles on the inverted margins of the bulbar conjunctiva. On the other hand, it can be the involvement of the cornea as well. Whenever there is an involvement of the cornea, you can just recall the histological features of the cornea. As I've already mentioned, it's an epitheliotropic virus. It is going to affect, or it is going to attack the epithelium. We can just recall by just having the basic knowledge towards the histological features and what was the particular epithelium of the cornea. It was basically a stratified squamous epithelium, which then was adjacent to a layer of columnar cells which had tight junctions. So that would basically provide the protective factors towards the corneal epithelium over here, and it's just going to affect the layer which was of the stratified squamous epithelium of the cornea. And then basically it can involve the layer of the collagen fibers, that is the stromal layer. And whenever, moreover, when I'll be discussing on the different types of the corneal ulcerations, I'll just focus on the fact that whenever the epithelium and along with that the stromal layer is also involved in the corneal ulcerations, then it would have a particular typical features of a discoid form. So it depends upon the extent of the damage that this virus is causing towards the corneal epithelium. Whatever the case may be, the usual presentation would be a punctate keratitis. So if we look at the features of the keratitis, or what would be the shape of the corneal ulcerations, it would be a rather punctate features that you'd observe in this kind of keratitis. And then of course there is another variety of these ulcerations which are known as dendritic ulcerations, which are more like just a tree-like pattern or a branching pattern. That is why they are known as dendritic ulcerations over here. Then we can have the another kind of this herpetic ocular lesions, which are the recurrent herpes over here. We have the active epithelial keratitis, and then we have the stromal, and of course, if the trophic layers are involved, we are going to term this kind of a condition as the trophic keratitis in these patients. Then we can have some of the patients who are suffering or who are also involving the iris of the eye, in which the conjunctiva, the cornea, as well as the iris, as well as the uveal apparatus is also involved. Of course, in these kind of patients, you already know if the uveal apparatus is involved, it is going to result in an increase in the intraocular pressure or a glaucomatous condition. And this kind of the herpetic infections would be termed as the herpetic iridocyclitis. Now, why do these recurrent herpes occur? You have to keep in mind that the basic pathogenesis towards the development of this recurrent herpes in these patients is that the virus basically communicates, or it rests down in some of the ganglions. Usually it's the ganglion for the fifth nerve, and then it reactivates and it regenerates and is going to attack the ocular structures. It can even attack the it can even present as the skin lesions, but usually the usual presentation would be the epithelial keratitis, or either it would be the iridocyclitis, and the patients would particularly give you a history of recurrences of these episodes in the past 6 months, or even over a period of 1 year. So this would be a particular history whenever there are these recurrences of these herpetic infections are observed in these patients. Now, the primary ocular herpes and their systemic features, we're going to look at that basically the patient would present with mild fever and malaise, a fatigued phenomena, generalized weakness that is observed by the patient. Then he or she would also complain of a non-suppurative lymphadenopathy, as well as it can be quite fatal whenever it is going to involve the encephalitis. The infections can obviously spread. The orbital cavity is in close communication with the cranial fossa. So whenever the infections spread through the superior orbital fissures or the inferior orbital fissures, and they involve the meningeal coverings or the brain itself, then it can be a condition of encephalitis that occurs. Obviously, it's one of the complications that we have to keep in mind, and we do not have to ignore these cases of ocular herpes. A multi-system failure can even result, and that would be obviously due to a complicated stage that you reach this phase of a multi-system organ failure in these patients. Skin and ocular lesions would consist of the vesicular lesions involving the skin of the periorbital region. So it's very important whenever these patients present to you with a decrease in the visual acuity and you find that there are these corneal ulcers that you find on examination, either dendritic or either punctate in origin or in shape. You're going to closely examine the skin that is the periocular skin particularly, and that would reveal the vesicular lesions that were particular or that were significant or signature lesions for the herpetic origin lesions. Then we have the vesicular lesions involving the skin of the face, lids, and even it can involve the lips of the patient. Then the patient may also complain of vesicular blepharitis, and sometimes it is one of the complications that you would observe in this patient. On examination and on close contact, you would see that he or she is also suffering from some mucopurulent discharge that is covering the lids of the patient. So blepharitis is basically a word used for any kind of infections or infectious states involving the lids and the lashes. So vesicular kind of a blepharitis is quite pathognomonic for the viral infections. Then we have the acute follicular conjunctivitis, as I've already mentioned, and we're already looking at the features. It's even involving the skin of the whole of the face. It's involving the conjunctiva, the cornea, the lids are even involved. So basically, all of the neighboring structures are at stake whenever we have a viral infection. Obviously, then we have the features of keratitis that we're already studying in detail. So just having studied a primary ocular herpes in which there is no recurrence, it was just a single episode that covered a time span of 2 to 3 weeks, and after treatment, it has a very good prognosis. Usually, there are cases which can be considered as the recurrent ocular herpes. So what are the features of this kind of a particular recurrence of these viral infections? The virus lies dormant in the trigeminal ganglion. So it's again very important that you keep in mind that it's the ganglion for the fifth cranial nerve that is involved over here. The virus basically goes out in a dormant state after the active infection has subsided, and then it reactivates and regenerates whenever there is a lower down immunity of the individual. So after there is a lower down immunity, it is going to regenerate and it's again going to attack the cornea, the conjunctiva. Again, the patient is going to suffer from skin lesions. So the patient would usually give you a history of a time span of usually 1 year in which he or she suffered from these episodes of ocular herpes or even herpetic lesions of the skin. They're usually not linked with systemic features, and typically it is usually a unilateral disease because there's a particular dermatome that is involved. So this dermatome that is particularly involved with the trigeminal nerve that is going to be affected because that is the activation route over here. Then obviously the predisposing stimuli would be fever, trauma, Any state in which the patient is immunocompromised, either he's debilitated, either he's malnourished, that would basically encompass or make the virus come into a state of reactivation and regeneration and reaching the state of infection in these patients. The epithelial keratitis over here would be presenting with redness and pain. Then obviously the patient would give you a history of tearing and decreased vision. So as we already know that cornea is a transparent structure that is located anteriorly to the lens, and that is basically having its own refractive index, and its transparency is very important for the functionality of the lens and making out the final image at the retina. So if the cornea is infected, if there is a cloudiness of the cornea that is observed, then obviously there would be a decreased visual acuity that the patient would complain of. Photophobia, that is also observed in bacterial keratitis. So it's one of the features even over here. So it's one of the overlapping feature over here with the bacterial kind of keratitis. The signs that you'd really observe in this epithelial keratitis is usually it can be a punctate epithelial keratitis having punctate lesions, isolated numerous lesions. They're usually known as the punctate phenomena. Then even the patients can present with this irregular ulceration, which is known as a dendritic ulcer, and that is usually highlighted whenever we are performing the immunofluorescence techniques. And then you can basically observe that this patient has a dendritic kind of ulcer. And even there can be these geographical ulcers. So these are the different shapes of the ulcers that can arise due to this epithelial kind of keratitis, which is caused by the herpes simplex virus. The specific treatment over here would consist of the antiviral drugs. Mainly, we'd be giving the ganciclovir and the vidarabine. So this is the most important drugs that we have to keep in mind. We previously performed mechanical debridement of the involved area, and at one time it was one of the treatment of choice to debride the area. But nowadays it's basically more subjected to give antiviral drugs rather than performing this debridement. But if the patient is of course allergic to these antiviral drugs or is not responding to these antiviral drugs, then of course we can combine or couple up this therapy with this debridement phenomena. Then of course there is the systemic antiviral drugs, for example acylclovir and valacylclovir. They can also be prescribed systemically. Usually they are given per oral TID, that is twice a day for a period of 3 weeks, that is 21 days. So this is the complete specific treatment for epithelial keratitis. The non-specific therapy would consist, and it's mostly similar to the treatment that was given in bacterial keratitis, involving the hot fermentation. And of course, you can cover up the photophobia by making the patient use the Jork goggles. A good diet is very important to increase the immunity of the patient. Fresh air and good rest. So these are the features that are going to increase the immunity of the patient and increase the overall health status of the individual. Another form, which is basically a type of a stromal keratitis, in which you have to remember that after the epithelium, we have a stromal layer, which is lying in close relation to the Bowman's layer. So if the stromal layer is also involved, then we would usually come across these kind of keratitis, which are known as the deciform keratitis. Usually due to the delayed hypersensitivity reactions to the herpes simplex virus antigens and the endotheliitis or the endothelial damage, it usually accompanies these kind of deciform keratitis in the patients, and it is resulting in the deciform corneal stromal edema. So even the stroma is involved in these cases. The infection has traveled all the way along the stratified squamous kind of epithelium, and it has involved the Bowman's layer and even the tight columnar junctional layer of the epithelium. So that would be the highlight over here. That's basically a more vernal variety of the herpes simplex virus that we're dealing with. The clinical features in this case would consist of the photophobia. Of course, there's a varied ocular discomfort that the patient would complain of. Then he or she would also be having a focal disc-shaped patch of the stromal edema. This is one of the signs, of course. And the folds in the Descemet's membrane would also be seen. So sometimes the whole of the stroma, and when we are recalling the layers of the cornea, again, I would like to emphasize that you should have the basic knowledge towards the layer of the cornea, because that is going to make the concepts more clear towards the different forms of this keratitis. If the Descemet's membrane is involved, it means that it has involved the whole of the cornea mostly. So it is going to be seen that there are these folds in the Descemet's membrane, the keratic precipitates, and then the Wesley's immune ring. So it's one of the kind, we have to remember that the Descemet's membrane was quite thick, and that would basically give off the immune ring. That would be the last to fight off this viral keratitis in these patients and give off this immunity ring. Corneal sensations would be decreased, and there would be an increase in the intraocular pressure. So you have to remember these are the very important points over here, that we have a decrease in the corneal sensations and an increase in the intraocular pressure, and this is going to distinguish the viral kind of keratitis from the bacterial keratitis, in which the sensations were completely normal in those cases. So the treatment over here would consist of diluted steroidal eye drops that is instilled 4 to 5 times a day for the antiviral cover, and then obviously the non-specific treatment would consist of providing with dark goggles, photophobia is covered, and as well as good rest, good diet, and fresh air, hot fermentation. These would be the non-specific treatments advised along with the specific treatment of deciform keratitis. The clinical features over here of the stromal necrotic keratitis, it's another variety of the keratitis. We've already studied a deciform keratitis, and as the name is indicating over here, there is a mass necrosis going on in this kind of keratitis, in this variety. The stroma is involved. There would be this cheesiest appearance that you'd usually observe. These are the typical signs for this necrotic kind of keratitis, and it's even going to involve the stroma, the Descemet's membrane, the Bowman's layer. The patient would complain of photophobia, and obviously you would observe that there is pain and redness observed by the patient. The corneal lesions, they include the cheesy infiltrates along with that. Mild iritis and keratic precipitates are also observed in these patients. There would be stromal vascularization that may be seen, and even there would be some sort of or some degree of congestion that is seen at the conjunctival level as well. So this would be a more virulent variety of viral keratitis that is seen. It's known as the stromal, and necrosis is also one of the features of this kind of keratitis. The treatment over here would consist of the systemic antiviral drugs in these patients are given. That would obviously include the ganciclovir, acyclovir. It can be given thrice a day for almost a period of 3 weeks. Keratoplasty is also done in these patients. Then we have another variety which is known as a metaherpetic keratitis. So in this kind, we have the characteristics. It's not quite an active viral disease. It's mostly severe form of the herpes simplex virus. The clinical features would consist of an indolent linear and ovoid epithelial defect that is seen over here, gray thickened margins and Ulcers are also observed over here. The treatment over here would consist of lubricants, banded soft contact lenses, and you can also perform tarsorrhaphy for these patients. Another variety over here is the herpes zoster ophthalmicus. Now, whenever we are considering this kind of a virus, we are done with the herpes simplex virus, and this is another variant which is of the viral type. As the name is indicating, the etiological factor over here is herpes zoster. It's again one of the variety which is basically causing the chicken pox in the children, and then it basically goes into a dormant state, and it is basically involving the ganglia ganglion of the fifth cranial nerve. It is going to reactivate from that ganglion and is going to reach the area and infect, or on reactivation whenever there is going to be a lowered immunity of the individual. So this is the basic pathogenesis that is linked with this kind of an ophthalmic condition which is known as herpes zoster ophthalmicus. The etiological factor is varicella zoster virus, which is causing the chicken pox in the children. And the pathogenesis over here would consist of basically it manifests as chicken pox in childhood. The virus becomes dormant in sensory ganglion of the trigeminal nerve known as the Gasner's ganglion, and it travels down to produce the cutaneous and ocular lesions. And you have to remember over here that it only happens whenever there is a lower down immunity of the individual. Either the patient had undergone a surgery or trauma, or he's in a state of malnourishment. The clinical features would consist of a frontal nerve that is more affected frequently. Hutchinson's rule is very important. That is basically whenever there would be an involvement of the bridge of the nose, then only the ocular lesions are more importantly seen in the patient, because that is basically the bridge of the nose is affected whenever there is the involvement of the nasociliary nerve. And whenever this nasociliary nerve is involved, then only you can observe that the patient will also suffer from the ocular lesions. So this kind of a rule is known as the Hutchinson's rule over here. The ocular complications, they occur in 50% of the cases, and the lesions are usually limited to a side of the head and the midline. So these are the typical features that are associated with herpes zoster ophthalmicus. The phases, first of all, there would be a phase of lesions. It can be in the form of skin lesions or even in the form of ocular manifestations, may totally resolve within a few weeks. Then there is a chronic phase of the lesions, and it may persist for even years. Finally, if even the virus, it goes again into a dormant phase, it can again reactivate, and there is a relapse that occurs, and that is known as a relapse phase lesion, where the acute or the chronic lesions, they reappear after a certain period of time. The acute phase lesions, how are they going to clinically present and how are you going to basically diagnose these cases is very important. The general features over here would consist of fever and malaise, severe neurological pain. When you look at the patient and when you look at closely at the cutaneous lesions of the patient, there would be the skin of the lids are mostly edematous, and there would be this vesicle formation, which is quite pathognomonic for viral kind of lesions, as you already know, as there are the vesicle formations in the chickenpox as well. The neurological complications would be the motor nerve palsy that would be seen along because of the involvement of the fifth nerve. Encephalitis and even neuritis may encompass this kind of a condition. The ocular lesions would consist of episcleritis and scleritis in these patients. Even conjunctivitis is seen, as well as when there would be the involvement of the cornea, you're going to observe that there would be this condition known as zoster keratitis. If the iris is involved, if the uveal system is involved, it is going to be termed as iridocyclitis, and as a result, there is going to be an increase in the intraocular pressure, which is known as the secondary glaucomatous condition. Necrosis and phthisis bulbi can occur due to the involvement of the trigeminal nerve, and the acute retinal necrosis can encompass along with all of the other structures being involved. Even the retina can be involved at this stage of the infections. The zoster keratitis can present clinically as these types. It can be a punctate form, as we saw in the herpes simplex type. It can be a dendritic form of the epithelial ulcers. Then there are these two additional forms, which are known as the numeral keratitis, or either they can have a disc-shaped or a ring-shaped appearance, which is known as a disciform keratitis in these patients. So these would be the typical kind of ulcers, or you can also call it a classification which is based upon the shape of the ulcers, which usually clinically present to you in the clinics. The chronic phase lesions would also give you the clinical features of neuralgias, of course, and the pain usually persists even after the skin lesions have disappeared and the features have disappeared, because there are the involvement of the neuralgic pain over here. The nerve is involved over here. The conjunctival lesions, they usually persist in the chronic phase, and they include the chronic mucus secretory conjunctivitis. The secretions can be mucus, or even they can be purulent in nature. Then even the sclera and the uveitis can be involved, and it may persist in the chronic form in these phases. Whenever there is involvement of the lid and the cornea, the patient would be giving you having basically ptosis, or either it can be the deranged appearance of the eyelashes, which is known as trichiasis. Exposure and mucus plaque keratitis is also observed in these patients. Why does this relapsing phase lesion occurs? Again, it can occur due to the lower down immunity whenever the virus goes into a dormant phase. It can represent as the numeral keratitis. It can even present as episcleritis or scleritis in these patients. Secondary glaucoma usually encompass these kind of keratitis, or whenever there is an involvement of the uveal system. As well as there can be a mucus plaque keratitis, which is noted down in these patients who already had suffered from an episode of herpes zoster ophthalmicus, and now they had a relapsing episode of this kind of a viral infection. Now, how do you treat these patients? The systemic therapy would consist of giving the antiviral drugs, the analgesics for the supportive treatment, because it's again very painful. So again, the pain is sometimes of a neuralgic origin, but you can all do try these analgesics along with that. Systemic steroids are given to inhibit the neuralgia, and sometimes this treatment is coupled up with cimetidine and amitriptyline. The local therapy for skin lesions caused due to the herpes zoster, you would ask the patient to apply the antibiotic and the steroidal skin ointments. Lotions, no calamine lotions. Apply cool zinc calamine. So this is more preferable rather than just calamine lotions. The local therapy for the ocular lesions would basically to give off for these secondary glaucoma, the treatment that is given off for the increased intraocular pressure, as well as to treat the zoster keratitis, iridocyclitis, and scleritis. For glaucoma, you're going to prescribe the patient with acetazolamide 250 milligrams, 0.5% timolol or 0.5% betaxolol. Topical acyl clover is prescribed 3% eye ointment for treating the keratitis. Cycloplegics like cyclopentolate eye drops are given, and along with that, this therapy, you're also going to give steroidal therapy to these patients. Now you have to note that we were usually avoiding the steroidal therapy in cases of herpes simplex virus, but over here you have to couple up these therapies along with the antiviral agents. The local therapy would also consist of the persistent epithelial defects. You'd be giving the lubricating artificial eye drops, bandage soft contact lenses for protection, of course. For secondary infections, we are going to prescribe the patient for antibiotics. And for mucus plaques, you're going to give the patients the mucolytics. So these are the some secondary problems that arise along with the major infection of the herpes zoster, and you're going to treat them accordingly, whatever the case is. If the patient has epithelial defects, that you're going to give him the contact lenses, and of course, if he's suffering from secondary infections, or if you're even suspecting that he might suffer from some secondary bacterial infections, you can prescribe the patient of some prophylactic antibiotics in this case. The surgical treatment would consist of the lateral tarsorrhaphy, which is usually done by the amniotic membrane transplantation over here. So just to cover up, or just to give off the damage that has been caused due to the herpes zoster, you're going to give the patient with the tissue adhesive with the bandage contact lenses and perform the keratoplasty for the visual rehabilitation. Of course, if there is a damaged cornea, the patient cannot see and his visual acuity has been decreased, so you need to perform the keratoplasty sooner or later in these patients. Then we have another variety, which is the protozoal keratitis. Usually the etiological factor over here is the acanthamoeba that is causing this kind of keratitis. The feature is the acanthamoeba castellini. So this is the biological name of the organism that is resulting in this acanthamoebic keratitis in the patients. The mode of infection over here, usually it's more common in the people who are using the contact lenses, using the homemade saline. Opportunistic infections in patients with other ocular keratitis, and it can be even preceding a mild trauma or saltwater diving. So these are some of the risk factors or making the person more prone to the development of this kind of acanthamoebic keratitis. The symptoms of this kind of protozoal kind of an infection are pain and watering. The patient would give you a history of a blurred vision that he has observed, a foreign body sensation, photophobia, and blepharospasm. That is basically, there would be the lids involvement, an irritative phase in which the lids are also involved, and there is a feeling of foreign body sensation and an inflamed condition of the lids over here. The epithelial roughening and irregularities are observed, and when you look closely, you'll observe that there are epithelial ridges. Pseudodendrites are formed over here, and epithelial and subepithelial curvilinear opacities are also formed on the slit lamp examination whenever done on the patient. The lesions would be typically ring-shaped lesions that were observed in the cornea. Radial keratoneuritis is observed, and also it can be, if it's a severe form of an infection, an abscess can even be seen in a ring form. Sometimes the sclera or even the limbus is involved, and in most of the cases, even the conjunctiva is involved in these kind of particular cases of acanthamoebic lesions. The differential diagnosis would obviously consist of even the viral kind of keratitis. It can be even the suppurative keratitis presenting with hypopyon formation, or the fungal kind of keratitis. So these are the differentials that you have to keep in mind, and you have to rule out these phases over here. The diagnosis is obviously based upon when you perform a potassium hydroxide mount in these patients, and CFW stains are given that are quite indicative of the fact. And then obviously you can take the biopsies of the cornea for the further investigations. PCRs are also done for any kind of a viral node if it is noted down in these individuals. And then obviously we can also perform cultures to rule out any sorts of bacterial kind of causative factors towards the development of keratitis. Then the lactophenol cotton blue stained films are used. Culture on the non-nutrient agar is also used, and then we have the confocal microscopy. So the histological findings and just isolating the organism which is involved in a particular infection is one of the most definitive ways to rule out where either it is a bacterial origin or either if it is of a viral, fungal, or either the protozoal kind of an origin in this kind of a keratitis. Specific treatments would consist of diamidines, aminoglycosides, imidazoles, of course, which are quite importantly used or significantly used in the treatments of protozoal infections. And we can also couple up this therapy with bigonides. There is always a multi-drug approach in these patients, giving the propamidine or hexanidine with PHMB. Then we have the chlorhexidine, which is combined with neomycin, another prophylactically used antibiotic if you're suspecting that the patient might be suffering from any superimposed kind of bacterial infections in any case. Paromycin is already coupled up with clotrimazole or miconazole, which is another antifungal kind of a treatment. Paromycin with drugs that is, for example, itraconazoles are sometimes coupled up with this kind of a paromycin treatment. So you can observe that usually the treatment, the antifungals are coupled up with the protozoal drugs, or either you are coupling up the bacterial kind of a treatment with these protozoal drugs because you're suspecting that the patient might suffer from these infections, and you can give these treatments prophylactically in these patients. The specific treatment would consist of oral ketoconazole, 200 milligrams BID, and penetrating keratoplasty is the surgical kind of the treatment which is prescribed to the patients. Of course, there can be a use of a prophylactic therapy with PHMB, and prophylaxis is obviously better in these patients just to avoid any sorts of complications that can occur. So in this lecture, basically, we summarized the basic viral infections which can result in the corneal ulcerations, and as well as some of the protozoal kind of infections, primarily the acanthamoebic infections which can even eventually result in the corneal ulcerations. How do you differentially diagnose these cases? And then how do you manage to get to a definitive diagnosis in these cases is quite interesting. So that is the end of this lecture. Thank you for watching sqadia.com.